So great. So he's a 26-year-old male. He plays kabaddi. He plays in both the positions as a raider and in defense. It's his dominant leg which he has hurt, and like it happened 2 weeks back, he doesn't have any previous history of injuries, and he had to limp off the mat. And this is he in front of you in the clinic. So like we have on panel an eminent orthopedic surgeon and 2 eminent physios who like must be dealing with this day in day out. So let us start with the orthopedic guys. Vikram, can you just come and demonstrate how you would go about and just take us through?
All right. So the first thing for me is he is a elite athlete. He needs to get back to sport as quickly as possible. The first thing I'd ask him is, and very pertinently explained by Abhishek, that how did he get off the mat? Did he need to be carried away or did he limp off the mat? That gives me some indication as to how severe the injury was. Was it an ACL alone? Was it an ACL plus injury? Are we looking at some rotatory problems, etc.? All right, when he says he limped off, it tells me that, all right, it could be a relatively moderate grade tear, but a person like him has great pain tolerance because they're used to doing the sport. So let's not assume things. So the first thing, gait, etc., we've seen. I believe a lot in physical examination before I go on to the knee. So the first thing I want to check is this easy. One sec, Abhishek. Sorry, can I have a look at you? Okay, good. I won't hurt you. If I hurt you, you tell me. Is I take this little thumb here and I try to see whether he can go all the way and touch his forearm here, right? So he can more or less do that if someone can focus. So I call these guys superhumans because people that achieve this level of athletics.
I'll give you an example. You can do that on me.
You can do that on me. So Abhishek, I know you cycle. So you must be great yourself. See, he has the same thing. So he's got laxity. So somebody...
I can go all over here also.
You can go all over here too, right? So the bottom line here is that he's in the wrong profession. He should have been an athlete and won gold medals for India, but he's doing very well as an orthopedic surgeon too. But people like this are blessed, but it's a boon and a bane because before they have an injury, the amount of pain that they have. So pain is a protective reflex. So the amount of pain before an injury is very short. So the duration between the onset of symptoms and an injury is really short, and hence they have injuries. They're superhuman because they don't get pain with certain activities. So here, I can't go beyond this. So this is a very important sign you need to check. Along with that, of course, elbow hyperextension, etc. But for me, this seals the deal, right? Once you've done this, I know we are dealing with somebody with hyperlaxity. Hence, I need to be very careful. Number one, to assess the other knee also, to see they have some inherent level of laxity on both sides. So just assuming that you have a a grade 2 Lachman, etc., may not seal the deal vis-a-vis it being a ACL injury per se. Number two, it also influences what I do as an arthroscopic surgeon to reconstruct his ACL, because what's important is the way I position my graft, etc. So such people usually have a lot of hyperextension in their knee. So let's see, right? So if I put it down here, right, and I extend, right, in his case, so important is to use your hand. आप मुझे बता दीजिए अगर दर्द हो रहा है, I'll stop, okay? Put your hand down, put your hand on his knee and lift his heel off. So it's not too much. I'd say it's about 5 degrees of hyperextension. I wouldn't call that too much, so that's okay. I do that on the other leg too. It's more, right? Why is it more? Because this is the non-injured leg, right? So this is my standard point, right? So don't assume that this is okay. It could be a locked meniscus tear, right? The reason I showed you on this is, if I were to just rely on this, I'd go ahead and say there's no hyperlaxity. But if I look at his other side, there's a reasonable amount of hyperlaxity on this side. It's at least about 10 degrees off the bed, all right? Next, coming to the knee, of course, looking at it in general, all right, to see for any swelling, etc., any prominences that you can see on either side. Then, of course, we start our range of motion. That's the amount he can bend, and that's very important for you physios, because you do a lot of prehab before you send the patients to us. So you can ask him to bend his knee. Sir, can you bend your knee? How much can you go? Not beyond this. So for me, a prerequisite before doing any kind of intervention is at least 90 degrees of flexion, all right? If a patient can do 90 degrees of flexion and I'm contemplating a reconstruction, I'm quite happy, all right? So he's about 92 weeks, it's par. I'm sure he's done some great rehab with one of you all. Then comes, of course, when he's able to reach 90 degrees, I can, technically speaking, attempt the anterior draw test. All right. So in his case, I'm just going to try something. Let me know again if you have pain. Can you bend, sir? Okay. मैं इसके ऊपर थोड़ा बैठने वाला हूँ. So I like to sit on the patient's foot, all right, so that he doesn't move it, all right. And I like to put my hands behind to feel the hamstrings. So my index fingers are feeling the hamstrings. My thumbs are in front, all right, over the tibial plateau, and I am basically doing an anterior translatory force to feel the tibia glide over the femur. And this is a subjective test to see how much is it gliding, number one, and number two, what kind of an endpoint. Is it soft, right, or is it hard? Is it like stopping? Now, why is that important? Now, a lot of PCL tears that you have, where the knee is actually subluxated backwards, when you pull it, it appears as if it's an anterior draw test, but it's actually a hard endpoint, right? So it's not. So lo behold, you'll be quite surprised to see that it's something else that's broken, and the ACL many times looks broken because there's something called pseudo laxity, right? Okay, so once I do this, it's very important for me to check the other side also, right? So I'm going to ask him, isko aap relax kariye, I'm going to ask him to bend this. Again, I'm going to be sitting on his leg, all right, and I'm going to be pulling it forward, yeah, but here there's hardly any movement. So here I could feel reasonable amount of translation, but here I can't feel any translation on this side, all right. I do a little bit of a modification of the Lachman test. Now, for the anterior draw, you need to be able to get this patient to bend to a certain extent, which many times may not be possible in a acute situation or if there's any other tear associated with it. So then the Lachman works very well. So the best way is I use my left knee for the right knee of the patient.
You're checking the hams to be not tight or
not
taut.
Tight, right.
So the position in which the patient is supine or sitting or something, is it important as long as the muscles are supple?
So as long as the muscles are supple, I'm fine about it, and as long as the foot is grounded. So for me, the foot needs to be grounded because all the force then acts on the upper end of the tibia rather than elsewhere in the joint. All right. So I like to do this. I put my knee under the patient's knee, right? Now what this does is, in a way, it relaxes his hamstring muscles. Then I use this part of my hand, all right, under his upper end of the tibia. Just relax, sir. Just keep your leg down. Just don't worry, okay? And I pull it upwards, right, to see whether there's excessive translation or not. Okay. So this helps me. I would say a lot of times, more often than not, this test is positive, but the anterior draw many times may be a little confounding and may not be positive. So this helps me do it in my. The third is, of course, the pivot shift test. Now, technically speaking, the pivot shift test is a test that should not be attempted in the, in your clinic. It's a test that's normally done under anesthesia. But I'm not a sadist, but I attempt it in most of my patients, especially those that have come to me after 2-3 weeks of their injury. I've had great physios like you taking care of them. So they're relatively pain-free. So I give it one shot in the way I do it. And if it is elicitable in my clinic without causing much pain to my patient, then that changes the management of my patient and the way I approach such a patient. Because that leads me into a whole new world called rotatory instability, and the way to manage rotatory instability and the stuff to find for rotatory instability is different. So this is the way I do it, all right? मैं एक test करने वाला हूँ. So I just hold his leg here, under my leg, under my axilla. I keep it here, and I just see whether there's any rotatory instability here. Okay, so here I can't find much in him. Okay, I'm not putting much force. So ideally speaking, it's done in a different way. You basically put it, then you rotate it. If you're able to elicit a pivot shift test like this should change your plan because your counseling of the patient is going to be different. Okay, so you can see he was not very upset or whatever with me, and I'm still alive. So then I get him to bend his knee. This is my seal the deal test when it comes to this guy. Okay. Though you have the McMurray's, etc., these are all very, I would say, not very reliable tests. The most reliable test to check your meniscus is the joint line tendons. It's a very easy test to do. All right. You run your finger through the medial joint line. दर्द हो रहा है कहीं पे? यहाँ पे. Okay. All right. So he has pain on the medial aspect of the joint line. यहाँ पे sir. On the lateral, there's no pain. So medial aspect, what could it be? It could be a condyle damage, it could be a meniscus tear, it could be the MCL. Alright, I haven't checked any of them yet, but this gives me a idea that it could be either one of these, injuries that I could suspect. Okay. Third is, of course, we check the collaterals along with this. Extension and in about 30 degrees of flexion. So extension, valgus force. So he has some opening on the medial side. So he has some element of medial collateral laxity that I can see here. Alright, no lateral collateral. Then I do it in flexion, in about 30 degrees of flexion, and do the same thing. It's opening up again in 30 degrees of flexion, but not opening up on the lateral side. So in him, I would anticipate that there could be MCL, there could be ACL. I can't rule out a meniscus without looking at the MRI, because the MRI is the best test. But with his knee slightly, not hyperextending as much as the other side, it should be on my mind. But MCL injuries provide a great amount of fibrosis and scarring, which could lead to some element of stiffness.
Great, thank you. So I think that was quite detailed. Anything different, Ashutosh and Anuja, you would like to see quickly maybe and just tell us some more physio pointers?
Is this on? This is on?
Yeah, your lapel mics are on.
What's his name? Sorry.
Rishikesh.
Rishikesh. Today Ashutosh is the lead, I am his assistant.
Okay, fine. Rishikesh, so basically Dr. Vikram covered most of the areas from a diagnostic point of view. He performed Latchman and different types of ACL diagnostic tests along with some collaterals, and he covered most of the diagnostic tests. Sometimes patient doesn't come to us with a proper diagnosis, so he can walk into us without having an MRI, or he can directly come to us. So in that case, appropriate history taking will be very important. So questions like at the onset, if there was any pop, if there was any locking or effusion signs, it's very important from a physio point of view if you're looking at the patient independently. So I'm going to just ask him if he felt any of such signs at that point. So आपको जब injury हुआ था, तब did you heard anything? कुछ आवाज़ आया, कुछ pop snap ऐसा आया? तो were you able to walk immediately कि तुम गिर गए नीचे? And आपको कैसे लेके गए वहाँ पे? उठा के लेके गए. और next day कैसा था तुम्हारा? Next day swelling immediately आया था कि next day आया swelling? Immediately आया. और तुम्हारा knee range of motion अच्छा था? Movement was possible? और knee lock हो गया था तुम्हारा? Knee lock था completely. So you were having difficulty to extend the knee as well. Or there was loss of balance as well. So these special questions are important to know, and we can anticipate some sort of hypothesis out of the information. Apart from the diagnostic tests, what we can add is actually checking the contraction of the quadriceps. So what we normally, this is just addition to what doctor has done already, is we can look at the contraction of the quads on both the sides. So आप दोनों quadriceps को contract कर पाओ?
I would just like to add, as Ashutosh is doing the test, so especially, if the person is, you are a team physio, or, you are traveling with your team or individual athletes, and let's say if such kind of incident happens in front of you, then what, that's why Ashutosh was saying, just, take a little history taking, just don't send them off, to a referred practitioner or for investigation. It's very important for us to understand what's happening, where to go, especially when we travel away from our cities, because we may not have the required infra around us, and then do you want to bring back the athlete to your city and then go ahead with the referring to certain practitioners or the investigation?
Yeah, definitely. So what I can see here is his unaffected side, the contraction of the quads is very good, as opposed to the affected side. Just contract again. The contraction of the VMO is very much delayed. So possibly there is some internal effusion that is causing arthrogenic inhibition of the quads. So along with that, as Dr. Vikram has already demonstrated the knee range of motion, we can recheck the knee range and see if there is any pain discomfort. And obviously the hyperextension range. I'm not going to perform the diagnostic test again, considering the injury. What we can add is the effusion grading. That is very important. So a simple stroke test to see, and we can grade the effusion. So So here, I don't see any major effusion out there, so which is a good sign. So that's the range part. Another important thing,
Just a little bit of patellofemoral if you want to check if he has any patellofemoral component. One test I would like to redo again, because for females sometimes, we see kabaddi players who can be really huge. For females sometimes it's difficult to hold with one hand and try to do varus valgus testing. I will just show you a little trick which I learned from my teachers from Australia. If you're a female, if the athlete is really big, try to hold it in your, on the side. Both the hands are free to palpate the knee, as well as to create, if you rotate your trunk, it can create varus and valgus forces. So this is a little trick for females out there, where you can be small and athlete can be bigger.
so from a strength point of view, it's important to see the function of the quadriceps. So just up late jao, niche. So simple test to do is an SLR test. So ye pair ko seedha uthana hai upar. Okay, and if he's able to assess the strength, so upar press karna hai. So this can give you an idea whether there is any extension lag, and we can check the strength of the quads. Uthao. And
I don't know
upar
if you
press
can
karna hai.
appreciate, but his quads are like shivering.
Press. So you can initially do a submaximal test. Abhi thoda aur zor se press karna hai, theek hai? So you can see that knee is starting to flex a little bit. So that shows that there is not enough firing of the quadriceps for his affected sides. Other things that can be done apart from the strength of the quads is to assess the proximal hip control, hip strength. So we can check the hip abductors, extensors, external rotators. We can check the athlete functionally also, because one of the criteria for surgery is good functional strength. So if you are able to get an athlete to a single leg squat level, provided it's an isolated ACL tear. So single leg squat having good strength and symmetry, at least around 90% is a good readiness for surgery. So if you can get that athlete into a single leg squat strength position, is a good prognostic indicator. Lot of other ways are there to check the strength objectively. So use of handheld dynamometer to check the quadriceps and hamstring strength, and you can get the ratios and get an athlete to a level where he is having optimal strength before the surgery. So those are the optimal signs and good indicators.
I'll just chip in here. So let's say Rishikesh will probably undergo conservative management or surgical management, and we are preparing for him for the surgery. It will be important to check the ankle range of motion as well, big toe, ankle. So knee to wall, if he can able to do knee to wall. As the doctor already said, knee hyperextension is a really important parameter. Hip internal and external rotation. I will just try if I can check his hip range of motion here. Rishikesh, एकदम relax रहिए. Knee में pain हो रहा है या hip में? Knee में pain हो रहा है. Okay, so I will not go obviously further into the range of motion to check the same. Is this okay? So just getting a sense of if his hip is also having any injury. If you are assessing him for the first time, the other side looks fine. Just check a little bit of soft tissue integrity. So let's say a hip flexor, QL, quadricep, hamstring from behind for the spasm. If we have to work on him, if we are training him for prehab going into the surgery. And because we practice Miten a lot, I would like to check the intra-articular mobility of ankle, hip joint, facetal joint, and the central lumbar spine. That would be some additional
Great.
points from me.
I think it covered most of the questions that I wanted to ask. I think, thank you very much. I think it's important that we see the patient as a whole and not only have a telescopic or arthroscopic, as we surgeons do, arthroscopic vision on the knee. I think most points are taken care of, like AP instability with someone with a high BMI. Anuja showed how a petite girl can kind of also still examine. Quad wasting was emphasized by Ashutosh and Anuja and Vikram. Hyperextension. We will discuss these questions later in our case specific scenarios. Anything else? Miten, you want to chip in on examination?
I will just add, Abhishek, just one point again. Related to varus valgus testing, I'll show you what can be the handhold for a female and relatively larger athlete. If you want to do Lachman again, doctor already showed it. So this will take off the hamstring spasm a lot. Again, females cannot grab, the tibia, and then they try to pull it and they cannot elicit, and they think that it's a negative, which is a false negative test. You can use your forearm and go under the, completely under the tibia, but make sure that you're not pulling medially or laterally. Make sure the forces are still translating posterior, anteriorly.
Super session.
Anjana had one question.
Yeah, I think
Girth measurement would be recommended?
We can do girth
doctors?
measurement, especially if the athlete is, your own athlete, you have seen him in the past, so then you will have lots of data points with you already. So it always helps that if you have pre-injury assessment with you at the clinic, or if you are a traveling physio, team physio, and then when the athlete gets injured, it's really, beneficial for us to compare to the pre-injury status of the athlete.
I think from our physio point of view, getting a pre-surgery evaluation and progressions are very important. I think girth assessment, yes, can be done, because with the effusion there is a lot of wasting. And we can always have that as a baseline. As I said about having objective strength assessment, it can be in the form of handheld dynamometer, a simple knee extension strength at 90 or multiple angles, even the hamstring strength in sitting can be a good objective measure. And a simple functional assessment before the surgery can be a good information for the surgeons actually, because considering his status, he is hypermobile, he may lack control issues at the hip or core, and if he is not worked at all during his prehab, his post-surgery rehab timelines might differ. So it's then advisable for him to undergo a proper prehab phase, so he addresses on these parameters, and then we repeat it just before the surgery if he is undergoing a surgery.
Thanks. One quick question last.
Ma'am, when we are checking the SLR test for assessing the quadriceps strength, when it is an already unstable knee, do we still do the test because we are increasing the anterior tibial translation and injuring the ACL further?
Yeah, I think Ashutosh was just trying to show you that whether, its ability to hold the knee and raise in SLR, that's what he was just trying to say. It's not the end point of it. You can take the player in a sitting position and then use your dynamometer or MMT or IMT to check his quadriceps strength.
I think the SLR probably may not anteriorly translate the tibia, in my opinion. First you check the SLR, see whether athlete is able to do it or not, if there is a lag or not, and you can see the quality of movement. If he is able to do SLR, then try and attempt the strength. You can do it above the knee also, without loading the actual tibia.
Okay, just a quick question. Can repeated testing convert a partial tear into a complete one?
No.
Depends on what you're doing. If you're making him run, if you're making him do some agility and complex balance testing, then he may land up with.
I mean, if we find athlete comfortable, then Rishikesh also, we can take him down, do some single leg testing, some balance testing, even try to see if he has confidence to get into a little bit of single leg squatting, etc. I don't think you would end up tearing that ligament.
So technically, single leg squat is reported in the literature. You need to have good single leg squat strength. Even hop tests are being reported. But if he's not able to do, don't even try.
2 weeks.
So I might check his walking. I might check his sit to stand partial.
Yeah.
If he is painful there, I'm not going to check single leg squat at all. Then probably discuss with the surgeons. He may have some chondral issue, some meniscal issue, some because he says he's had some locking there. So
yeah,
we don't know.
Meniscus is something we could not check.
So we don't know. And as doctor said, on MRI, he's able to differentiate properly.
This session has
I think we'll stop over here.